sir started sharing screen. Good. Tushar Parikh sir is going to speak on the neonatal shock and role of echo. Uh, Now, as we are becoming more technology savvy and managing more than sick babies, the hemodynamic issues and shock part. This is something hot topic in neonatology, and without that, I know few people or few neonatologists is really difficult to take around. Also, there are people's uh, like even I am one of them. Like it's like without echo machine, we it's really difficult to take around, and without screening the baby's heart and brain and even kidneys, lungs, sometimes we feel that something is missed. So to speak on this topic on shock, Tushar sir, our own very humble and very academic person, neonatologist from Pune. Sir has done his DM from Mumbai, and sir has been to the various posts at the IAP in the IAP and NNF, in the even in the Secretary of Maharashtra State previously. He's a PG guide for neonatology at KM Pune, more than 40 publications. He has done pioneering work in stand for eco, and he's one of the author for textbook of eco and point of care ultrasound. He has done various ventilation workshop, various eco workshops at national and international level. And he's a trainer for NRP and SSK, and his research interest is in parentology, neonatal hemodynamics, advanced ventilation support, and taking care of micropremies. So thank you, sir. Thank you being part of and sparing your time, and hope like at the end we'll be out of shock and we'll able to manage all the shock. So we expect more of clinical aspects. Over to you, sir. Over to you, sir.
Thank you so much, Sunil. Good afternoon, everyone. First of all, I would like to thank Telangana State and Maharashtra State NNS to put up this program and to invite me for this program. As Sunil said, yes, point of care ultrasonography has become a center stage, and it has become almost like a handheld stethoscope for us now. Without that, managing a sick baby, it's very difficult. So in the next 30 minutes, we are I think 2:10 now. So in next 30 minutes, I'll try to be as fast as possible. But of course, I'll try and cover all the important aspects about neonatal shock and how our management of neonatal shock has changed after the advent of functional echocardiography in our lives. So to start off with that, so yes, so a healthy hemodynamic system requires these three important components. One is adequate volume of the blood in the system, ability of the heart to receive and pump the blood, and good vascular tone. So these three things are required for good tissue perfusion or a systemic blood flow, to say so. When we classify the shock, and later on when we are managing the babies based on the functional echocardiography, there also I am going to refer in the same manner, and therefore it is important to understand the classification of the shock. They are classified based upon whether if the volume of the blood is adequate. If it is not so, then it is a hypovolemic shock. If the ability of the heart to receive or pump the blood is reduced, then it is a cardiogenic shock. And if there is any issue with vascular tone and the blood is getting redistributed and not sufficiently going into the tissues, then we would call it as a distributive shock. Clinical causes, we all know blood loss, plasma loss, volume loss can be because of the hypovolemia. In the cardiogenic category, we know that there may be myocardial dysfunction because of the asphyxia, myocarditis, myopathy, arrhythmias, sometimes because of the obstructive causes, the heart fails. And when there is abnormal vasoregulation because of either sepsis or neurogenic causes, there can be peripheral vasodilatation, or sometimes because of the high use of inotropic agents, sometimes that can lead to peripheral vasoconstriction, or sepsis can cause peripheral vasoconstriction leading to abnormal vasoregulation. And sepsis typically has got mixed picture, part of some of the these three categories. So when we manage the baby shock, we basically clinically monitor the baby for the clinical signs of capillary fill time, peripheral pulses, bounding pulses, and blood pressure. Biochemically, we monitor the baby for lactate and the blood gases. And nowadays, we monitor these babies hemodynamically with the help of functional echocardiography. So in the next few minutes, I will take you through important cases, how we approach a baby with suspected shock scenario. So let's take this first case. The baby is 28 week, 1.1 kilo. Mother had 18 hours of PPROM. She had received 1 dose of steroid. It was an emergency LSCS. Baby had respiratory distress since birth. Baby had high oxygen requirement, moderate to severe distress. Baby was ventilated. Baby received 1 dose of surfactant. And over a period of next 6 hours, the baby remained stable. The oxygen requirement and the ventilator requirement, we could reduce it down. The FiO2 came down to 35%. The baby was getting stabilized, but at around 24 hours, we noticed that the baby had clinical evidence of shock. The baby had become a little pale. The mean blood pressure was 26, which was initially around 34. Capillary refill was around 3 to 4 seconds, and baby was appearing pale. Baby had passed urine so far. And of course, because of this, we again thought about various aspects, whether it is a sepsis, which is because the mother had leaking, whether it is intraventricular hemorrhage, or whether there is any other reason that the baby is having this particular presentation. So most of the units up until recently would have a protocol like this to give a volume of about 10-20 ml per kg. This is a survey from around 120 neonatologists in Canada, how they would approach a baby with shock. And then the second would be use of dopamine as a first inotrope of choice. And then 3 patterns: use of steroid, use of dobutamine, or use of epinephrine as per the protocol of the unit. However, surprisingly, only 14% units had proper protocols in place. Now, this particular publication is about 15 years old, but again, important lesson. Many of units are still practicing in this manner, and this is what is being practiced. But are we doing the right thing? There has been a lot of changing attitude towards volume expansion. Studies have shown that hypovolemia alone, without any apparent cause of blood loss, is a very uncommon cause of hypertension in newborn. Liberal or high fluid intake will be associated with increasing necrotizing enterocolitis, PDA, IVH, and death. And PDA may become symptomatic in the first few days in very low birth weight infant. And so, does the baby really need volume, and how much, and can it cause any problem at this stage? Studies have shown in a very low birth weight infant, the mean blood pressure does not have any correlation with a range of blood volumes starting from 40 ml to 140 ml. The mean blood volume in these babies was around 85 ml per kg. The blood volume was measured by dye dilution technique, and the baby's blood pressure was correlated with the blood volume of the baby. And what they showed is that there is no absolutely correlation in these babies as far as the blood volume versus blood pressure is concerned. So are we doing the right thing by giving volume? Also, inotropes. Which inotrope for which baby? Now, this has been an intense debate. Dopamine, we know, is a vasopressor. It increases the systemic vascular resistance. It increases the cardiac contractility. So you can imagine, on one end there is increase in vascular resistance, and on one end the heart is pumping, and we know that the duct is open at this stage. So a lot of people believe that in the presence of a large duct, using dopamine may be risky because you would be flooding the lungs. Dobutamine, we know that it's a pure inotrope, but it does not, it may not improve the cardiac, it may not improve the blood pressure because of its beta 2 action. It may increase the cardiac contractility, but it may not increase the blood pressure. What about milrinone? There are not adequate studies, and it is a lucitropic agent, but we need more studies. So treating the underlying cause, can there be hemodynamically large duct, and how to diagnose the PDA? Because clinically we know clinical signs are unreliable in the first few days to diagnose duct. There is a median delay of about 3 days, 4 days before the presence of duct and it becoming symptomatic. So this baby requires functional echo, and that is what we do in our unit. So this baby had a large duct. We thought about sepsis, we thought about blood loss, but this baby had PDA. Again, this is a pulsatile pattern. In the entire talk, I would try and restrict not to go in the technicalities of the procedure of the performing echo and getting the views and getting these indices. What I would like to clarify is more on the conceptual aspect of managing these babies. So this had a pulsatile flow and large duct, so we restricted the fluid. As per the policy of our unit, we started on ibuprofen. We continued with ventilation with little permissive hypercapnia strategy, which expects to increase the pulmonary vascular resistance to a certain degree. And the baby was extubated after 24 hours once the duct had little constriction and it was no more hemodynamically significant. Also, the practice change which has happened in the last 10 to 15 years is there is a less reliance on the blood pressure as a marker of shock. In a Canadian survey of 120 neonatologists, around 87% neonatologists would respond to a blood pressure value which is less than postmenstrual age. BAPM is a blood pressure less than postmenstrual age. That is, so suppose if the baby is 30 weeker and the mean blood pressure is 27 or 28, it is equal to hypotension as per this criteria. But we know that there is no scientific basis for this. There is no evidence to suggest that. And similarly, another international survey of 200 neonatologists, almost 75% of them they responded that the mean blood pressure below postmenstrual age they defined as hypotension. And studies from Sydney, this particular study is done by David Osborne to correlate between blood pressure and the tissue flow. And what they've shown is the SVC flow they have taken as a marker of systemic blood flow. Now, what is systemic blood flow? I'm going to cover it again later, but we have to understand that systemic blood flow is something which is actually going to the tissues. So when they correlated mean blood pressure with systemic blood flow or SVC flow, what they found out is that a lot of babies had a blood pressure which was less than 30, but they had adequate SVC flow. And on the other side, there were a lot of babies who had less systemic blood flow, but had a normal blood pressure. And therefore, they concluded that blood pressure does not correlate well with a SVC flow or a systemic blood flow. So this particular graph is very important. This particular chart is very important for those all who manage babies based on the functional echocardiography. This is how we go about a baby who is suspected to have a cardiovascular compromise. So by that, what I mean is that suppose clinically you find a baby having shock. Maybe it is because the baby is looking a little pale. Maybe there is a white pulse pressure. Maybe the baby is tachycardic, or maybe there is unexplained metabolic acidosis or high lactate. Wherever you clinically think that there may be a possibility of underlying shock or cardiovascular compromise, we look at this flowchart. We take the baby's blood pressure. We check the functional echocardic parameters. If the blood pressure is normal, if the functional echocardiographic wise baby has a normal cardiac output, generally this baby would require just the monitoring and follow-up. If the baby has hypotension, then you first rule out mechanical cause. Like say for example, in the first case where we are ventilating the baby, I would go back and see if the baby is receiving high mean airway pressures because of the surfactant. If there is any improvement in the underlying lung, that can cause lead to hypotension. So then you do a functional echocardiography, and in the functional echocardiography, what we look it as, we look at preload, we look at the heart for the cardiac contractility, we look at the cardiac output, and we look at the duct, the PDA. If the baby is hypovolemic, give volume expansion. If there is a problem with contractility, give inotropic agent which will improve the contractility, use dovitamin. If there is associated hypotension, then rather than using dovitamin, use dopamine in the absence of PDA. And if there is a PDA, treat PDA and allow increased pulmonary vascular resistance. If the shock is refractory, go back to the baby, do again assessment, and depending upon the finding, you may choose to use volume, inotrope, steroid, adrenaline, etc. Now, the functional echo, so this is what I said, we assess the baby for shock with preload, cardiac contractility, and cardiac output. Now, how do we assess the cardiac preload? We use subcostal long axis view, and we take the longitudinal view of the IVC, and we measure the IVC around 1 to 2 centimeter from the IVC RA junction. And what we measure is we measure the baby IVC size, maximum diameter versus minimum diameter. Now, this is different for a baby who is spontaneously breathing or a baby who is on a ventilator. But the key is that you measure a widest diameter and the narrowest diameter in the cardiac cycle, and see the studies have shown that IVC diameter has a good correlation with the size of the baby, that is gestation or birth weight. However, it does not correlate with the CVP. What correlates with CVP is these two parameters, the ratio of minimum diameter versus maximum diameter, and IVC collapsibility index. So I'll enumerate here. So you do subcostal view, take the IVC in the picture, get the M mode, get the size of the IVC, the maximum diameter and minimum diameter, take the ratio of minimum versus maximum, that is the IVC diameter ratio. This IVC diameter ratio is, if it is less than 0.5, you are certain that the baby has got a low CVP, that is less than 5. In a baby who has got high CVP, those babies will have this ratio above zero point 0.8. However, contrary is not true. If the ratio is above zero point 0.8, not necessarily it would mean that the baby has got high CVP. Second important aspect is IVC collapsibility index. Now, IVC collapsibility index is determined by the same method, and where there is you take the ratio of minimum diameter and maximum diameter and put it in this equation, d max minus d minimum divided by d max. And if this, and these studies have shown that this particular ratio has got a linear inverse correlation with CVP. So if this ratio is above 0.4, it would indicate CVP less than 5, and if the ratio is less than 0.15, it would indicate a CVP of more than 10. So if the collapsibility is less than 15%, it indicates high CVP, and if the collapsibility is more than 40%, it indicates there is a low CVP. So this we use in clinical practice. But again, most of the times, this I keep on telling my residents also, that if you find one index, one particular value out of range, don't get excited. You have to always take all the echo parameters in the clinical context of the baby and then treat. Don't treat echo, don't treat your functional echo single parameter. Take everything into account, take the clinical picture into account, and then treat. Along with IVC indices, look at the left ventricular size, look at the hyperkinetic nature of the left ventricle and right ventricle, and see if the fractional shortening is normal or very high, and look at the IVC diameter with respiratory variations. So these are the pointers towards low preload. So once you look at the preload, then you look at the cardiac contractility. Now this is a parasternal long axis view, and these are the various parameters that you took into account: fractional shortening, ejection fraction, and velocity of circumferential shortening. So based upon that, you can calculate the fractional shortening, and this is the formula. Fractional shortening is normally between 25 to 40%. If it is less than that, then it would indicate that the baby's heart contractility is reduced. Now, many times there are clinical scenarios where there it is very obvious. The heart is dilated, and as you can see, the walls are not coming close to each other. The valve is opening and closing, but the walls are not opposing to each other. Now, this is a very clear-cut picture where the baby has got a kind of axe in the head, where you don't need to ask. This heart is not pumping at all, and many times you would come to a situation where there is sepsis or hypoxia. You would find that the heart is not contracting enough. Now, third important aspect is calculating the cardiac output. Now, the cardiac output can be calculated for right ventricle, and it can be calculated for the left ventricle. Normally, there is a formula for this. Cardiac output is equal to stroke volume multiplied by the heart rate. Stroke volume is calculated by velocity time integral multiplied by cross-sectional area of the vessel. Now, this is a technical aspect. I would like you all to focus on the concept of cardiac output. Normally, the cardiac output is for both the ventricle is 150 to 300 ml, and this is how we calculate the aortic root diameter. And the machine gives you value of VTI, velocity time integral, and you put it into the formula to get the left ventricular measurement. Now, all the neonatal studies, you would find that there is something called a systemic blood flow which is referred. Ideally, left ventricular output is equal to right ventricular output. When there is if you see, the left ventricular output is measured here at this point, which is shown here, just beyond the aortic wall. Now, what happened once the blood ejected out of the aortic wall? A part of that is shunted across the PDA into the lungs, and whatever is going out beyond PDA is something which is going to the systemic circulation. So something beyond PDA going to the body, going to the tissue, is something called as systemic blood flow. The traditional methods of measurement of the left ventricular output or the right ventricular output, as you can see, they measure the flow of the blood just beyond the cardiac chamber, beyond the left ventricle and the right ventricle. Now, as you can see here in the picture, the left ventricle, the output is 400 ml. As it is going out, almost 300 ml of it is shunting across the PDA into the pulmonary circulation, that is coming back to the left ventricle, left atrium and left ventricle, and it is going into the circular motion. But what is going out into the aorta, distal aorta, arch of aorta, and to the body is about only 100. Now, this particular 100 ml of blood per kg is coming back to the right atrium and is being pumped by the right ventricle. So if you compare the LVO, the left ventricular output versus right ventricular output, you will see that the right ventricular output is something which is representing the amount of the blood which is going to the tissues and the body. And that is the concept of systemic blood flow. A lot of studies in the newborn, they would say that systemic blood flow is this much. So when we call it systemic blood flow, what correlates best with systemic blood flow among the LVO and RVO is the right ventricular output. So you calculate in the newborn, when you want to find out how much is the cardiac output in the presence of PDA, take right ventricular output. Now somebody would argue that right ventricular output gets may get abnormal when there is a presence of a PFO, shunt at the atrial level. But again, we have to remember shunts at the atrial level, they are of low volume shunt and they generally do not cause much of volume overload. And therefore, right ventricular output is a better marker of systemic blood flow. Now, I have purposefully not included SVC flow in this picture because SVC flow is more of a research tool, and SVC flow, even the people, Martin Clocco and group, they have done the work on SVC flow. Even they themselves are not using it in their day-to-day clinical practice. And there is a lot of variation, there is a lot of technical challenges, and the normative values are also challenging. So SVC flow is also something which is representative of systemic blood flow, but for this talk I have not included here. Then coming to fourth aspect of assessing a baby is assessment of the PDA. Now PDA, again we have to remember, is a normal structure at the time of birth, and therefore we monitor the PDA rather than diagnosing it the PDA. So when the baby is sick, when the baby is less than 30 weeks, we monitor the baby's PDA every 6 hourly, 12 hourly, and till the time it is not of kind of hemodynamic significance. There are specific echo markers of PDA which are based upon the size of the PDA, magnitude of the shunt, markers of the pulmonary overcirculation, and markers of the systemic steal. This is again just to give you example that in the first 72 hours, what we look at in the PDA is the pattern of blood flow in the PDA, and based upon that we decide whether we treat this duct or not. Now this is how we assess a baby with shock. Now I've taken a couple of cases just to highlight. Now this particular 28-weeker 1 kilo mother had PIH, emergency section for antepartum hemorrhage, sudden abruption was there, and baby was depressed, asphyxiated, required resuscitation. Baby was shifted to the NICU endotracheal tube. Baby received 10 ml per kg of normal saline bolus. Baby was ventilated over 18/5, and baby was pale, poor peripheral pulses were there. Capillary refill time was 3 seconds. Mean blood pressure was 28. Baby was hypotonic, poor movements, and baby had occasional gasping on ventilator. Now, what is the likely cause of shock? This particular baby has received 1 NS bolus. Baby is asphyxiated. So there could be hypovolemia. There could be problem with cardiac contractility because the baby also has evidence of asphyxia. So we did a echo, functional echo, and as you can see, the IVC is completely collapsed. There is hardly any opening of IVC with respiratory variation. And as you can see on the real-time echo also, the IVC pulsatility was very less. IVC was collapsed IVC, and you can see the heart chambers. They are of very small size. The ventricular wall is kissing the lateral wall of the ventricle, and so this is a hypercontractile ventricular chambers that you can see. So again, this baby had hypovolemia, which was not completely corrected. So we gave another bolus, and later on respiratory management was done, and the baby shock was corrected with IV fluids. And as you can see, follow up the IVC at with the fluid correction, the IVC the ratios, collapsibility ratios were normal. Coming to this third baby. Now in clinical practice, the cases are more complicated. This is the 34-weeker 1.2 kilo IUGR baby. Mother had PIH, eclampsia. Baby was asphyxiated, shifted to the NICU, was ventilated on the moderate settings with a effort of 70%. X-ray had a good lung expansion. At 3 hours, the baby had become pale and poor perfusion. Mean blood pressure was on lower side. Blood gas showed metabolic acidosis. And as you can see, the cardiac chambers were dilated. There was evidence of pulmonary hypertension. Many of you understand. There was evidence of pulmonary hypertension. Tricuspid regurgitation was there. The cardiac contractility was reduced. The fractional shortening was 24. And as you can see, the LAO ratio was also 2.5. And the blood flow in the main pulmonary artery blood flow is shown here 43, which is slightly on lower side. And as you can see through the PDA, there is a bidirectional shunt suggestive of significant pulmonary hypertension in this scenario. Arch was normal, and as you can see, the IVC was fully distended and it is almost non-pulsatile IVC. The collapsibility index was 0.16. technically on normal side, but little on kind of lower side, and the ratio of 0.83 again telling that it is a distended, almost non-pulsatile IVC. So with this echo assessment, what I know now is that this baby is at least fluid sufficient. I don't need to give any fluid for this baby. This baby's problem is cardiac contractility, so I need to support the baby's heart. This baby also has an issue of pulmonary hypertension, and this baby has a large duct, but the duct is shunting predominantly bidirectional. It's right to left shunt because the ratios, if you see, it's about more than 30%. So it's a bidirectional shunt where I don't need to close this duct. So this baby was treated with fluid restriction, inotropes, dopamine first to improve the contractility. Dopamine we would give if there is a significant systemic hypertension. Milrinone could be an add-on inotrope, and there is no medical treatment for PDA required at this time. Baby may require treatment for PPHN with the help of either sildenafil or nitric oxide. So this is what the overall assessment of the heart of this baby, and this is how we would treat the echo in this baby, treat the shock in this baby. So how do you select the inotrope in a baby with shock? Look at the blood pressure and look at the cardiac output. If the blood pressure is normal, cardiac output is normal, observe the baby. If the blood pressure is high or normal, but the low cardiac output is there, just support the cardiac contractility with the help of dobutamine or milrinone. If the blood pressure is low, but cardiac output is normal, it means that you need to use afterload pressors such as dopamine, epinephrine, or vasopressin. And if blood pressure is also low and cardiac output is also low, you need to use combined dopamine and dopamine, or you can use adrenaline, which will act on both. So this is how we would use inotropes based upon the functional echo findings. Now this is the last case. Suppose so this is a baby who's 2.1 kilo, referred to you on day 5 with respiratory distress, tachycardia, poor pulses, capillary refill was prolonged. There was a sclerema, severe respiratory distress, high oxygen requirement, bilateral pneumonitis on the X-ray, blood gas was staged of mixed acidosis. So clinically there was neonatal sepsis, there was respiratory failure, and so this baby was being ventilated, and there was evidence of shock. So when we assess the baby, as you can see, there was a distended non-pulsatile IVC. As you can see, the IVC, the baby, there are movements with breathing, but the IVC is not coming collapsing, and absolutely this thing. And the heart has a poor contractility. As you can see, there is opening and closing of the walls, but the cardiac chambers are not coming kind of compressing and opening. The fractional shortening was just 0.2, so suggestive that the cardiac contractility is reduced. There was evidence of some pulmonary hypertension, which happens most of the times when the baby is sick, and this pulmonary hypertension was measured on 41 millimeters of mercury. There was no PDA, thankfully, and the cardiac output was on higher side. We know that when the baby is in sepsis, many a times late onset sepsis would have high cardiac output. So this baby was given fluid restriction, inotrope of choice, because the blood pressure was also a problem. We used dopamine plus dobutamine. Ventilation was optimized, acidosis was corrected. The pulmonary hypertension came down with this, and systemic antibiotics here started. As you can see, the IVC became pulsatile, the fractional shorting. This is the next day. The IVC became pulsatile and the cardiac contractility improved, and the heart became kind of more responsive, more contractile, and as you can see, the VT, the cardiac output even further increased, normalized of the peer pressure. So in a situation of septic shock, we know that there can be combination of factors. So it can give you idea about preload, idea about contractility, cardiac output, hemodynamic consequences of PDA. It will tell you about pulmonary hypertension. It can give you idea about diastolic function of the heart. Now this is about assessment of the heart. But many times what we need to remember is that when you face a baby who suddenly becomes sick or suddenly becomes collapsed, in that scenario, what we do is the point of care assessment of the baby. And what we propose, what we do in our units is basically we look at the heart of the baby to look at the cardiac factors that we discussed. We also look for the structural screen of the heart. We look at the baby's head. There may be intracranial hemorrhage. We look at the cerebral artery Doppler to see the status of the cerebral circulation. We look at the baby's lungs, and we look at the baby line position if there is any line, and we look at the abdomen if there is any free fluid collection. So this is something what we do for a collapsed or unwell neonate. This we have been doing since last few years. Recently, last week, there is a publication by Yugen Singh and group that is called Safer Protocol for Suddenly Decompensating Neonate. Look at the baby's heart for tamponade, look at the lungs for tension pneumothorax, look at the pleural effusion, look at the aorta for critical aortic occlusion, which is very rare, and look at the baby's abdomen for free abdominal fluid. Now, this is a recent publication online 1 week back. But again, essentially, we are also coming towards protocols which are existent in adult medicine and emergency medicine, such as fast protocol or caveat protocol, etc. Again, each one with their own kind of merits. So this also something which we can use in our practice. We can find out tamponade, we can see pneumothorax, we can see pleural effusions, and we can see IVH also. And this is something which would complete the assessment of a baby with shock, besides doing the functional echo assessment of the baby. Again, summarizing the talk, functional echo will help you identify the underlying hemodynamic disturbance. It will help you to structurally screen the heart, helps to plan the therapy, helps in selecting inotrope, helps in monitoring the response to therapy. And emergency situations, it can be combined with point of care ultrasonography to identify the underlying other problems. Thank you so very much. I think it's a vast topic. The technical aspects I was not able to cover, obviously, because it's a workshop in itself. But the idea behind this talk was to give a conceptual idea how we kind of look at or address a baby with a shock, critically neonate who is on ventilator or not on ventilator, and we talk about respiratory therapy of that baby. The hemodynamic assessment of the baby is also very important. Thank you very much. If there are any questions, I'm happy to take.
Yes, sir. Thank you, sir. You tried to cover a lot of like all hemodynamics in one talk. Really difficult, as you said. But still, anyway, to just like overview, like you can manage clinically, combine clinical knowledge with echo. Don't go by just one finding. Use all the clinical map findings and echo findings in total to manage the baby with shock. There are some questions, representative questions, like Dr. Kaushal. She's asking, in resource poor setting like ours, can we prophylactically close PDA?
Correct. Now, prophylactic treatment of the PDA has gone through flip-flop kind of thing. So